That's good. So in the next hour, I'm going to talk to you about imaging of liver tumors. And so characterization of liver masses is the approval indication for the use of microbubbles pretty well worldwide. And so it struck me after doing these liver tumors for quite some time that there are some real fundamental principles that help us with the interpretation. And so I've put this together into a talk. So the approval indication is liver mass characterization. And so it answers the question, what is it? In other words, we know that there is a mass in the liver. Now, the second issue, of course, is referring to liver mass detection. And this answers the question, is it there? And so if we consider this last question, so liver mass detection, so all patients that have the big cancers, lung, breast, and colon, pretty well worldwide, there are screening techniques that are implemented for looking for liver metastases. And so that means that basically in all centers, there are countless examinations done every day, mostly with CT scan, but also with MR scan, looking for metastases. And so certainly in a contrast-enhanced ultrasound department, I don't think that we have the capacity or the ability to look at all the patients that require evaluation for liver masses. However, when you're doing your studies, it is always, as Richard pointed out, doing these sweeps looking for metastases is very helpful, and we find things that are not suspected, we find additional things, and so we are very good at this, but we would always do it more, I believe, in a problem-solving way. So coming back to liver mass characterization, there are well-established algorithms for diagnosis of liver masses. And so those for CEUS are now similar to those for the non-invasive diagnosis of liver masses on CT and MR scan. And these are based on enhancement characteristics that we see in the arterial and the portal venous phase. And then, of course, we recognize that contrast-enhanced ultrasound has the unique advantage of the best temporal resolution, which supplies us with really exquisite vessel morphology, which helps us with our diagnoses. So the objectives that I have for this presentation are to highlight the fundamental principles for interpretation of liver masses on contrast-enhanced ultrasound. And we have two major questions that we're always asking ourselves. And the first one is it malignant? So we're looking at a mass and we want to know, is this mass important? Is it malignant? Or is it in fact benign? And then the second question that we ask ourselves is, can we establish a specific diagnosis? And so we'll cover both of these. So pearl number one that we have is for the determination of malignancy. And so very early on, in fact, in the very first study that we did, we found that the analysis of the data showed that based on the observation of the lesional enhancement in the portal venous and late phase relative to the liver, we can look for a decline in the enhancement so that it drops down below the liver. And this is referred to as washout. And washout has a strong association with malignant outcome. Now, there are always exceptions, but nonetheless, this is the rule. So let's just look at a couple of cases. So if we look at a patient that has a contrast-enhanced CT scan and a contrast-enhanced ultrasound, we can see that at images that are not necessarily taken at the very same time, but at the peak of the arterial phase, that we're looking at a hyper-enhancing mass in the liver with somewhat of a central scar. And you can see that there's concordance. This is a very important thing. We know that CT and MR are established as the gold standards, so we're always looking, how do we compare to them? So this is concordant. And of course, as we go along, we can see that perhaps again at a slightly different interval in time, but both of these lesions have dropped down. So the liver in the portal venous phase enhances progressively more. The liver gets blood supply from the hepatic artery and the portal vein. So over time, the liver will enhance more. Our tumors, in many cases, are supplied only by the hepatic artery, and in this case, you can see that the mass is less enhanced. So this is a beautiful example of washout, and this is a malignant tumor shown with equivalence, really, on the CT and the ultrasound scan. So let's look at another patient, a young asymptomatic woman. And so here we're looking at the left lobe of the liver, and in the peak of arterial phase, we can see on both of these that, again, we're looking at a hyper-enhancing mass, in this case, a homogeneous enhancing mass. Now, as we go along into the portal venous phase, we can see on the CT scan that the mass is attenuating with the liver, whereas on the ultrasound scan, the mass is actually still enhanced to a greater extent. So there's our mass, still hyper-enhanced, and there's our liver, which is less enhanced. And so this is, again, equivalent result. And so this sustained enhancement, where the enhancement stays equivalent or remains greater than the liver, this, in fact, suggests to us a benign outcome, and this is a classic FNH. And so pearl number 2, we leave that about the washout for a while, is that when we consider benign tumors that we will often encounter during CEUS, that their diagnosis, they're characterized by specific vascular and filling patterns in the arterial phase. And so these arterial phase patterns that characterize these benign tumors are optimally shown on real-time dynamic CEUS. And this is what we record, as beautifully shown by Andrej and Richard. This is our wash-in clip that we store when we do our scans. And so this is an old slide, but Peter Burns and I made this when we were at the beginning of our looking at masses. And so this includes the 3 common benign tumors that we encounter in the liver. So hemangioma and FNH are both very prevalent. We see them often. Adenoma is much less common, and it actually has one of the outliers for this rule. But so when we look at the gray bar that we have here, we can see that this represents what happens in the arterial phase. So you can see that our schematic shows specific and quite different pictures for what happens to the hemangioma, what happens to the FNH, and what happens to the adenoma. But where we have some similarity is that when we look in the portal phase and the late phase, is there's a tendency for these lesions to have sustained enhancement. And so this is very true for hemangioma, very true for FNH, and adenoma, of course, is the outlier, and so it's one of the exceptions. Now, adenoma is a very uncommon tumor, so if you consider all of the benign lesions that we see, the rule that sustained enhancement has a strong association with benignancy applies. So let's look at these tumors and at their special features they have in the arterial phase. So in the arterial phase, these tumors are characterized by peripheral nodular enhancement, which is not continuous. They have centripetal progression of this enhancement in either the arterial or the portal venous phase. In other words, it may happen very quickly in the arterial phase or more slowly. And in the portal venous phase, they have sustained enhancement. And so here's an example of such a hemangioma where we can see that at 8, 20 seconds, and at 1 minute, we've got progressive enhancement of these lesions. And so let's look at another hemangioma. And so this is a patient who has a large mass in the liver. And when we inject the contrast, we can see on our schematic those peripheral globules that characterize these lesions. And when we look at the actual tumor, you can see its striking similarity to our schematic. And so these schematics were made by my student, David Burrows, and we published a whole thing on characterization of masses in radiographics almost 2 years ago now. And I think that this is a very, very helpful thing. And one of the things that you can see about these tumors as compared to others that I'll show you is that these pools of blood that occur in these hemangiomas, they don't represent as linear vessels. So when we're looking at the other tumors, we'll see beautiful vessels, and we don't see them in hemangioma because these are just pools of blood that occur within the tumor. Now, when we look at these lesions over time, you can see that they don't always fill in completely as here, but at 2 minutes, the lesion's still quite bright with a big black pool inside. And at 3 minutes, the black area has gone down further, but the lesion shows very striking sustained enhancement so that the mass is brighter than the adjacent liver. Now, what about this patient? So this is a patient with hepatitis B virus, and so this is a surveillance scan. So when we look at our still images, you can see at 11 seconds, the lesion's got a rim of peripheral nodules. At 20 seconds, it's completely filled in, and at 4 minutes, we still continue to show that sustained enhancement. And so in actual fact, when we're doing liver imaging, we always want to watch for a long time because we don't want to miss any lesion that might wash out in the late phase. So we do watch, and then we want to also confirm that benign lesions do in fact have sustained enhancement because we want our technique of contrast-enhanced ultrasound to be a reliable technique where if we call something a hemangioma or an FNH, that our clinical colleagues can count on us to be correct without having to go to confirmation with another test. So let's look at the clip on this patient. So there you can see when we inject the contrast, you can see that the lesion is contrast avid, so it's enhancing much more quickly than the adjacent parenchyma. And so this lesion enhanced very, very quickly and then shows that sustained enhancement. And here's another patient, HBV surveillance. So there's this small nodule in the liver right at our threshold of about 1 centimeter. So when we look at this, again, we have to be right on the lesion. You can see that the patient's breathing, but it's still fine. And you can see how quickly that nodule fills in little puddles on the periphery. So even though that's a very tiny lesion, we can see the centripetal filling from the periphery to the center. And we can go back within the clip. The best images that you'll take will not be images that you fire blindly. They'll be acquired within an AVI clip, and then you back up and pick out the frames that you want. So at 23 seconds, at 30 seconds, completely filled in. And so this is a homogeneously enhanced mass. At 1 minute, we have a beautiful image still showing it enhanced. And when we look at 4 minutes, the liver's now starting to decline a little, but you can see that our mass remains very bright. And so this is a flash-filling hemangioma. So this can be a full stop. There's no way this is going to be an HCC or any kind of cancer. There's no washout, and the arterial phase features are classic. Now, let me show you, this patient does have a subsequent MR. And so when we look on the T1 vibe, we can see the lesion. And the best image, of course, is on T2 because hemangiomas are bright on T2. But when you look at the images that are taken post-GAD, you can see that in the arterial phase and in the delayed phase, this doesn't show those peripheral puddles, and it doesn't show the centripetal progression. And instead, it just shows a uniformly enhanced nodule. So this is, in fact, an indeterminate MR scan. And the reason that we have a big advantage here, and these are the advantages your clinicians will realize that you have with CEUS as time goes along. So MR and CT scan take a snapshot in time. And on that snapshot in time, they're not taking it in the very, very early arterial phase, and they don't show the sequential filling. So if you have a flash-filling hemangioma, this is the typical result where you have a uniformly enhanced mass with no washout. And so we know, of course, that that can be one of the patterns that small early HCCs can have, so that makes this indeterminate on MR. And so these advantages of CEUS are beautifully shown in many cases, and this is another one. So this is a patient with HBV cirrhosis. So the patient comes for a surveillance scan, and on the baseline scan, we don't see the nodule, but in the arterial phase, you can see very nicely that we have the hyper-enhancing nodule, and then in the delayed phase imaging, we can see that it doesn't wash out. So again, an indeterminate result. So the patient is not referred for CEUS. According to the liver guidelines, you should go from CT to MR scan. So the problem is that CT and MR have the very same problem. So on the MR scan, we can see that that's a T1 dark nodule, and it enhances, and again, it doesn't show washout. So in this at-risk patient for HCC, CT and MR are indeterminate. So when the patient comes to us, we can see the abnormal liver. There's a nodule beautifully shown in segment 2, and we can do elastography to confirm, in fact, that this would be an at-risk liver. So here we have a definite value for the speed of our ARFE, and so this is a cirrhotic liver. And when we do a flash reperfusion technique, you can see that we can see the nodules hyper-enhanced, and when we destroy the microbubbles and watch the lesion refill, you can see the filling from the periphery to the center of the mass. So a classic flash filling hemangioma, and this is a full stop. And so these kinds of lesions are the things that now our CT and MR colleagues rely on us to be able to say this, to remove patients from that continuing follow-up on CT and MR for indeterminate results. And as I've said, the best pictures that we get by backing up our AVI clip and pulling the frames out that show this beautiful peripheral puddles of enhancement, discontinuous puddles with centripetal progression, and then sustained enhancement for 4 or 5 minutes. Now, let's leave hemangioma and talk about focal nodular hyperplasia. So this is a very, very common lesion as well, although not as frequent as hemangioma. So what are these lesions characterized by? Well, they're homogeneously hypervascular in the arterial phase. They have stellate vascularity and a centrifugal filling pattern. And in the portal venous phase, they show sustained enhancement, often with an unenhanced scar. And so when we look at a patient, 29-year-old asymptomatic woman, this is the most common part of the population for discovery of FNH. So we can see a rather interesting looking mass. It's about the same echogenicity as the liver, but very, very well marginated mass. So when we look at this with our bubble tracking techniques, so the conventional fills in, and then we can destroy the bubbles and then watch the lesion fill and refill. And so that pattern from the center unquestionably, and so these patterns are not always so obvious, but when you're looking at a lesion that's filling from the center to the periphery, if you can't see the beautiful stellate vessels as well as we can here, the other feature that we find invaluable is that the lesions look like they get bigger over time, whereas lesions that fill from the periphery don't show any change in their size. And so this allows us, again, to back up and get those beautiful frames when we're looking at these tumors. So now what's pearl number 3 going to be? Well, benign tumors, in addition to showing these very specific enhancement features, generally show sustained enhancement. And we've already shown you this. So in the portal venous and late phase, a benign tumor tends to be characterized by a sustained enhancement. Now, there are always exceptions to these rules, and so hepatic adenoma, the last lesion that we haven't looked at, a very rare lesion that we don't see nearly as often, and so they show late week washout in about half of the lesions that we see. So let's look at these lesions. So adenomas are very significant lesions. They're not the same in significance as hemangiomas and FNH. And this is because they have a recognized risk for either bleeding, and a certain percentage of them can have malignant transformation. So the fact that some of these have washout is okay in my mind, because we often biopsy these, and these are often removed as well. So the fact that they have different enhancement features is of value. Now, if we do see an enhancement pattern for these, they fill centripetally from the periphery to the center, but not with puddles like hemangioma. Rather, they have a chaotic, dysmorphic vascular pattern. And about half of these lesions, as I've said, will show sustained enhancement, and the other half will show late weak washout. So let's look at a really lovely example where we have concern. So this is a 25-year-old female who has a very generous and a very bright and fatty liver. So her liver alone is concerning. And she's had 6 months of right upper quadrant pain. She's already had an indeterminate CT and MR result. So when we look at her, you can see a large, well-defined hypoechoic mass in her liver. So when we do CEUS, you can see that this is certainly not a hemangioma, and it's definitely not an FNH. So it fills from the periphery rather into the center, but it doesn't have a real good direction or anything, and the filling is heterogeneous. So not a beautiful pattern like the other lesions. So when we look at our 11-second, our 44-second, and then at our 3-minute scan, there's washout. So this is a patient that's a young female with a fatty liver. And so do I think she has HCC? I don't think she does, although the pattern could be that of HCC. And so in this case, I would say that the lesion has washout. Therefore, it's part of our group of lesions that we're worried about, and that we think that a hepatic adenoma is a definite possibility. And so in such a large lesion as this patient did have a biopsy, but it was what's called a big excisional biopsy. They took it out, and this is a confirmed hepatic adenoma. And so hepatic adenomas over about 5 centimeters in size, which this is, they are routinely removed surgically because of their really significant risk of catastrophic bleeding and also malignancy. Now, so before we leave these beautiful benign lesions, so I'm just showing you here 3 bubble accumulation techniques on 3 different lesions. So if we look at the nodule in the upper right corner, I mean, you can all tell me, what is that? Beautiful stellate vessels filling from the center to the periphery. That's a classic FNH. We are just suspicious of it the moment we see it, and we do perform still late imaging just to confirm that there is no washout. Now, if we go to the bottom of these clips on the right, there is a lesion that fills with peripheral puddles that are discontinuous from the periphery into the center of the lesion. And you can see how the technique allows us really superb visualization of the liver vasculature as well. But so that's a classic hemangioma. So this is, again, the enhancement pattern in the arterial phase. So let's go to our bottom left clip. And this is, again, on an asymptomatic woman. And so the clip will start over in just a moment now. So it fills from the periphery into the center, but not with beautiful vessels like we have on the FNH, but more of a dysmorphic pattern. And so this was one that we thought for certain would be an adenoma, and that lesion showed sustained enhancement. And so just to remember, this exquisite vessel morphology helps us when we do comparison studies with CT and MR, because you won't see these kinds of vascular filling patterns on those techniques. So let's leave those lovely benign lesions and go on to something else. So we've already talked about the fact, is it malignant? So we're looking for that washout. And so malignant lesions are not diagnosed by their arterial phase pattern of enhancement. They are suspected from washout. And so if we look at the top 2 images there, is that a malignant lesion? So there's no washout. So if no, likely this will be benign. Whereas the bottom lesion on a man that came to our emergency department with abdominal pain, you can see that this liver mass that we found hyperenhances, shows washout. We're thinking, yes, it's malignant. And when we searched his whole abdomen, we found additionally a carcinoma in his sigmoid colon. So let's go on to some malignant things. So pearl number 4 is, let's talk about metastases. So metastases are characterized by rapid and complete washout. And this is often so rapid that it occurs within the traditional arterial phase. So when we look at metastases and look at our schematic, you can see that the thing that's constant to all of the metastases is that they appear as a black punched out hole in the portal venous phase. Whereas when we look at the gray bar for metastases, you can see that within the gray bar, so what are the arterial patterns? Really, it encompasses everything. They can have rim enhancement, in fact, often have rim enhancement. They can be diffusely enhancing, as some of our benign lesions were, or they can be hypoenhancing. But regardless of what they do in the arterial phase, they're characterized by rapid washout. And so these are 3 different patients, and they all have metastatic disease. So the patient on the left has a rim-enhancing mass, the patient in the middle has a hyper-enhancing mass, and the patient on the right has 2 hypoenhancing masses. But all of these are proven metastatic disease. Now, when we consider malignant tumors, the timing of washout is discriminatory. And so metastases, as we've already talked about, their washout timing is very fast, and it often occurs within when we're looking at the wash-in, as soon as we see the peak enhancement, we can almost look just a few seconds more and start to see the lesions start to wash out. And they tend, most often, if we watch them long enough, to wash out completely. So this was a patient that came to us where I didn't have any history, I didn't know anything, just with a mass on his outside ultrasound. So when we look at that grayscale ultrasound on the left, we can see a liver that doesn't have too much in the way of features, and then we can see that hypoechoic mass. So we know that hypoechoic and hyperechoic masses can be cancer and can be benign, but certainly a black mass like that in that liver, that's concerning. So then you can see on our lovely clip, so that when we inject the contrast, that the lesion enhances very rapidly, so it's avidly enhancing in the arterial phase more than the adjacent liver. And then this is a 20-second clip roughly, and you can see that right before our eyes, within the time frame of the arterial phase, the lesion has already completely enhanced and then is washing out. And so when we go back in our clip and we take our images, at 12 seconds it's hyper enhanced, definitely enhancing before the liver parenchyma, but at 23 seconds the liver is now caught up, and you can see that the lesion shows washout. And then when we look further on, you can see the much increased conspicuity of that mass when we look at it after 2 minutes. Now, pearl number 5, contrast-enhanced ultrasound in the portal venous phase improves detection of metastases over baseline because it improves their conspicuity, and this allows us to see both more and smaller lesions than we would otherwise see. And so in a study that Peter Burns and I participated in way back in 2001, 2002, we found, in comparison to CT scan, that CEUS was actually equivalent for detection of metastases and superior in some circumstances. And so this was published a long time ago in Radiology. But so let's look at an example of how this benefits. So here's a patient who has a hypoechoic mass in the liver. And then when we go to our low MI image right before we inject the contrast, we can see perhaps a little bit better. And this happens sometimes because of the different imaging technique for that low MI image. So when we inject the contrast at 15 seconds, we see a heterogeneous mass that's slightly hypoenhanced relative to the liver. So it becomes more enhanced but still heterogeneous at 17 seconds, and perhaps even more enhanced by 22 seconds. But by 27 seconds, the liver's coming up and now the nodule's going down. So it's starting to wash out. So there is no doubt that we can see this better at 40 seconds, and you'll notice that the small adjacent satellite nodule becomes more obvious as we get closer to the portal venous phase. And if we look much later, you can see that now both nodules are very black and we can see them very well. And so if we do a sweep of the liver at that time, we have much increased detection. So sweeping the liver in the portal venous phase is the optimal time and the technique for detection of liver metastases. So this is a very old case, but I've always kept it because I've never gotten a better one. So this was a patient who came to my emergency department when I was in Toronto, and the patient came for an ultrasound, and one of my colleagues read this ultrasound, and he called the liver normal and commented on the ascites. And when I look at these pictures, I think that's a fairly good call. It doesn't look like there's very much in that liver to me. So a very astute anesthetist was asked to put this patient to sleep, thinking that he had a leaking aortic aneurysm. And so he phoned me and he said, "Stephanie, can you bring those bubbles to the OR?" He said, "I don't think we should anesthetize this patient." He said, "His liver feels like a rock." And I thought, well, there's a good clinical exam from the anesthetist who's putting the patient to sleep. But so we take our bubbles, go to the operating room, and when we inject, you can see immediately that that very normal looking liver on the baseline is filled with lesions in the arterial phase. And of course, even more lesions when we come to the portal venous phase. So this is a pattern of diffuse metastatic disease. Now, how often does this happen? It doesn't happen very often. I've said to you, this is a very old case, and I've never replaced it because I've never had a better one. But the bottom line is, although this doesn't happen like dramatic numbers of lesions, you have to remember that metastatic lesions can be occult on baseline on ultrasound, but also on CT and MR scan. They don't show. And so we need this contrast to really show what's going on. And so certainly we always think that you shouldn't interpret a CT or an MR for metastatic disease without contrast. And really you shouldn't interpret an ultrasound for metastatic disease without contrast either. So Pearl number 7, malignant tumors show washout, and the timing and intensity of the washout are discriminatory. So hepatocellular carcinoma is characterized by weak and late washout, and non-hepatocellular malignancy by rapid and marked washout. And so if we have our 2x2 graph, we can see that if we have intensity and timing on our Y and X axis, that the late and weak washout will be HCC, whereas the rapid marked washout will be non-hepatocellular malignancy. So let's look at a patient. This is a 63-year-old male who comes to my emergency department with abdominal pain, and he has no risk factors, so he just was having an ultrasound, and we came across this very black mass. So as I've mentioned to you, black masses always concern me, so we did a contrast ultrasound. So at the peak of the arterial phase scan, you can see that the mass is homogeneously enhanced. So do we know what this mass is? No, we just don't know what it is. And so we can see our clip when we inject the contrast, and so it just enhances, it just becomes enhanced. It doesn't have a pattern. It didn't look like, certainly not a hemangioma, not an FNH, and it's not going to be an adenoma in this patient. And so we can see it enhance. At 1 minute, it's still hyper-enhanced. At 90 seconds, it's still hyper-enhanced. I can't see it there at all. And so as we continue to watch, though, you can see that perhaps at just over 3 minutes that the lesion is starting to wash out. And when we get to 4.5 minutes, there's definitely washout. So what does this show us? It shows us a mass that's hyper-enhancing and that it shows late weak washout. Now, this is not a risk patient, so we do elastography. He does not have a cirrhotic liver, but the pattern is still that of hepatocellular carcinoma. So in my own experience, we call this a probable HCC in a normal liver, and this is a confirmed HCC in a normal liver. And so the enhancement patterns are very helpful on CEUS. So that hyper-enhancing mass with that late weak washout. And so by weak washout, you can see that although the lesion's black, it's got bubbles in it still. It still has little flecks of the contrast agent within, which makes the washout weak. And just another example to emphasize this element about time. So here's a patient with HBV, a 73-year-old patient with a lovely mass. And here, this is a very helpful clip. You can see that this patient and many other patients, they don't hold their breath. So either they don't hear us, they don't want to hear us, they don't understand us, or they don't want to hold their breath, but they don't. And so although this is absolutely destructive to MR scans, so we never go to HPB rounds 1 week without having at least one scan that's compromised by breathing. And so on CEUS, I think Andrej and Richard emphasized that we always want to take a lot of time getting ready. So even though this patient's breathing, we're looking from an intercostal approach, and our nodule stays within our plane of visualization, and we can see that very well. So we take our image at the peak of the arterial phase, and you can see how avid the tumor is for the contrast as compared to the liver, which has barely enhanced when the nodule is already enhanced. At 1 minute, the nodule is still hyper-enhanced relative to the liver, which is catching up. And at 2 minutes, it's completely invisible, whereas at 3 minutes, the nodule has got late and weak washout. And there's still bubbles left, but there's definite washout. So now, pearl number 8, non-hepatocellular malignancy often shows rim enhancement and rapid and marked washout. So what is this similar to? It's similar to metastases, and very often we can't tell which of the non-hepatocellular malignancies we're looking at, and these lesions frequently come to biopsy. So let's talk about cholangiocarcinoma. So it has an increased incidence with liver cirrhosis, as does hepatocellular carcinoma. However, it has different characteristics when we do CEUS in both the arterial and the portal venous phase, and it allows us to be suspicious for a non-hepatocellular tumor. So let's look at this patient. A patient who's 78 years old, has hepatitis B virus, and he has a nodule on his surveillance ultrasound scan in 2013. And so when we look at this, this is not RMR, but I got these pictures from elsewhere. But you can see this very, very small enhancing nodule on this MR scan. And the nodule does not show washout, so it's very small, less than 1.5 centimeters. It's enhanced and doesn't show washout. So they thought that this was possibly a hemangioma, and in this patient, this was unfortunately ignored. However, in 2015, somehow the patient gets back in for another surveillance ultrasound, and they say it's grown a lot. So of course he has, again, an urgent MR scan. So you can see the nodule has grown a lot, and now we can see in the arterial phase in the center a fairly uniformly enhancing mass, and then on the right-hand image, in the delayed phase, the nodule remains enhanced. And so this is suspicious but indeterminate. So this patient comes for CEUS, and we can see a nice subdiaphragmatic hypoechoic mass in this liver. And when we do our CEUS in the arterial phase, we show the same as what they show. At 16 seconds, a uniformly hyper-enhancing mass in the liver. Now at 25 seconds, it looks like there might be a small area inside that's starting to wash out. And then at 30 seconds, there's no doubt that this is washing out. So although the MR scan shows increasing enhancement with no washout, on ultrasound, we definitely show washout. So when we look at the MR scan in the late phase and the late phase CEUS, this is discordance. So over time, this discordance shows it's very helpful to me. So whenever I see this, where we think something washes out and MR thinks it doesn't, the first thing I think about is this patient has cholangiocarcinoma. So this discordance is of interest. Now, let's look at another similar patient. This is a woman who has an echogenic mass in the same part of her liver, subdiaphragmatic liver. So when we do her contrast-enhanced ultrasound, you can see easily that she's got a hyper-enhancing rim pattern to this mass. So as soon as we have a rim pattern, we're thinking of different pathologies. And so there's our images we have at the top, a rim arterial phase hyper-enhancement, And then we have rapid washout again at 30 seconds. So this is, again, a cholangiocarcinoma. And when we look at the MR, arterial, and late phase, we can see an unusual pattern with kind of a rim as well, with increasing enhancement in the central part of this mass over time. And so what we know is that rapid washout on CEUS with sustained enhancement or increasing enhancement on CT or MR scan suggests that this is likely due to pseudo-enhancement on the CT and MR scan. And when is this encountered most? In non-hepatocellular malignancy, where there are tumors with permeable vascular membranes and fibrostroma. So this is a schematic that one of my students made for us many years ago. So we know that there's an interstitial phase for CT and MR contrast. And so this is related to vascular permeability, and the most permeability occurs in these non-hepatocellular malignancies. So when we look at the intensity of the enhancement, it relates to the vascular volume, but perhaps most to the vessel permeability. So contrast that with the microbubble contrast agents. So the microbubble contrast agents cannot pass through the endothelium into the interstitium. So therefore, they're purely intravascular. And so there, the intensity of the enhancement in the arterial and the portal venous phase relates only to the vascular volume. So HCC versus ICC, the arterial phase hyperenhancement is different. HCC usually uniform, ICC frequently rim or hyperechoic, but it's the washout that's different. So HCC usually shows late and weak washout, and the ICC is rapid and punched out. But the biggest value I found in my own experience is that when we have discordance with CT and MR, we always want to consider non-hepatocellular malignancy, and particularly ICC. I haven't even got my program. Perfect. So this is an 82-year-old female who has mid-abdominal pain, and she has no risk factors, so this is her presenting scan with this great big mass in her abdomen in segment 8. Now, when we look at these pictures, these arrows are pointing to the surface of her liver, and so this is an example of surface retraction. And for those of you who do MR and CT scan, it's much easier to see on CT and MR, but very nicely shown here as well. So this large hyperenhancing mass is evaluated with CEUS, and so again, you can see that she's breathing easily, which doesn't bother much at all, and we can see a hyperenhancing rim to this tumor. And when we look at her further, we can see that at 47 seconds, the whole mass has washed out. So this is a mass with rim enhancement with washout before 1 minute, and it's exaggerated more at 1.5 minutes. And so this again suggests to us that this will be malignancy. So washout tells us malignant, rapid washout tells us we have to consider non-hepatocellular malignancy. And what is this? This is a peripheral cholangiocarcinoma in a normal liver. Now, at 3 minutes, you can see how much our big mass has washed out, but you can see also that in the rest of her liver, we see what were quite occult baseline satellite nodules. And so we always want to look for these, and we find many, many of these. So the ultrasound pearls that we've looked at is that washout is the most important indicator of malignancy. And so we always want to look for a long time to see if there's either rapid or delayed washout. And then we showed at the beginning of the talk that benign tumors are characterized by specific enhancement patterns shown in the arterial phase. And these are beautifully shown on ultrasound because of the real-time capability of ultrasound. So we have excellent both spatial and temporal resolution, which allows us to see these patterns, which aren't shown as well on CT and MR, where they take a snapshot in time. And sustained enhancement generally suggests a benign outcome, although there are exceptions to all these rules. Now, the hallmark features of metastatic disease is rapid marked washout. Timing and intensity of washout is discriminatory between HCC and non-hepatocellular malignancy. HCC is characterized by late and weak washout, whereas non-hepatocellular carcinoma is characterized by rapid and marked washout. Now, intravascular microbubble contrast agents will show washout when interstitial contrast agents for CT and MR scan may show instead increasing pseudo-enhancement. Thanks for your attention. Are there any questions? No.